שלום לכולם. כעת נשמע הרצאה בנושא השפעת מגפת הקורונה על התנהגות בריאות, טיפול רפואי ובריאות נפש, מאת פרופסור לינדה וייט, גם אותה אציג באנגלית, שתדבר גם באנגלית. Professor Linda Waite is the George Herbert Mead Distinguished Service Professor of Sociology at the University of Chicago and Senior Fellow at NORC at the University of Chicago. She is the principal investigator of the National Social Life, Health, and Aging Project, NSHAP. As part of NSHAP's multidisciplinary investigatory team, Waite has participated in a COVID sub-study and numerous ancillary studies. Professor Waite has received numerous honors and awards for her scholarly contributions, and she is an elected member of the American Academy of Arts and Sciences. Following her lecture, we'll open up for a discussion with the audience led by Professor Alex Weinreb.
Thank you. Thank you all for coming. Thank you for inviting me to this really interesting conference. Thank you for giving me an excuse to come to Israel again. Both of my children and all of my grandchildren live here, so any opportunity I get, I'm here. So what I was asked to do today, and let me just lay out University of Chicago lecture rules. Please ask questions as we go if they're points of information, or you think I'm completely wrong, or you want to argue with me, or whatever. It's fine. Or hold them to the end. If it's a point of information, by the end it won't be relevant, so ask it as we're going if you want to. So I was asked to talk about our social world, and what's happened because of COVID. And I was delighted to do this because the project I work on, the National Social Life, Health, and Aging Project, which is funded by the National Institutes on Aging of the National Institutes of Health, carried out a COVID study. And so I actually know what at least people tell us about what happened to them during COVID. So that's what I'm going to talk about today. And this is obviously very new, but I want to start by telling you about NSHAP because the COVID study was a sub-study of NSHAP and built on NSHAP and actually gives us longitudinal information on the people we speak to both before COVID and what they say happened to them during COVID. So it's not just a cross-section. We can actually compare their lives from before to their lives now. So NSHAP was designed to look at the relationship between what I'm calling social health, and I'll tell you what I mean, and the other components of health, like cognition, physical functioning, diseases, mental health, as people age. How all of these components of health and everything else fit together to affect well-being at older ages. We wanted to identify the pathways through which social stuff affects and is affected by other components of health and other things. We expected to find that people with strong functioning social relationships showed better trajectories of health than people who were either missing those relationships or whose relationships function poorly. We designed the study in the early 2000s. We received funding after a couple of tries and designed the survey and started the survey part of the project in 2005. The NSHAP is a survey of initially 3,000 community-dwelling older adults, ages 57 to 85 when they were first impaneled, living around the country. So that was our first contact, just over 3,000 people. We spent, well, I'll tell you that in a minute. We have since added a cohort of respondents. We interviewed the first set in 2005 and 2010, and then in 2015, we added a younger cohort. So that year, 2015, which is the base of our COVID study, that's the last time we saw them before COVID, we had about 4,477 people. Each of them, we've completed 3 rounds of data collection, and the data are publicly available, so if you have any interest in using them, I can tell you how to get them. You can just download them off the net. We did these interviews in person. We were in each person's home for about 2 hours. An hour of that was survey interviews, and an hour of that was like a mini medical exam. That's not, I'm not going to talk much about that. I can later if anybody wants to know. But we didn't do anything with that, excuse me, during COVID, the COVID study, because we didn't go to people's homes for obvious reasons. So I wanted to say a little bit about what NSHAP measures in the social world, just the big areas. We obviously, since it was a study about social relationships, social participation, social support, all of those things, we asked them many, many, many invasive questions about their lives and their intimate relationships. Just as an example, excuse me, we ask a lot about sexuality. These are almost all married couples or single people. I'd consider those invasive questions. And most people answered them, and they've been really, really, really important, I think. It's an important component of social life in adulthood. So we know that strong social ties contribute to health, which means larger social networks, more diverse social networks, high-quality relationships, a well-connected network. Social participation, we know it's a different level. If you think that intimate relationships are the one-to-one. Social networks are sort of the group-to-one. Social participation is the larger institutions and the individuals participating in them. Religious services, a very important part of social participation. Getting together informally with neighbors or friends, attending meetings of organized groups like your book club or a bowling league. Is there bowling in Israel?
Very little.
Yeah, okay. I'm not sure, you're missing much. And volunteering. Obviously, close relationships. I started out talking just about spousal relationships, but I realized that's too narrow. Marriage and partnership, obviously, those are close personal relationships. It turns out, and we've got now a lot of information on this, it's not just whether you have them, but the quality. And for many, having a poor quality relationship is equivalent in its impact on health to having no relationship at all. But parent-child relationships are very important, and sibling relationships can be very important. And then the last one, and I'm going to talk more about this, is loneliness and social isolation. So Professor Fisher mentioned loneliness. Loneliness is the feeling that your social relationships are not meeting your needs. Social isolation is actually not having relationships. One is perceived and one is objective. And that's going to turn out to be an important stratifier in the effect of the social world on COVID, or COVID on the social world. So the questions in NSHAP on loneliness ask how often in the last 2 weeks you felt left out, you felt like you lacked companionship, and you felt isolated. The questions on social isolation were, do you live alone? How often do you actually see other people? And what's your social network like? It's a little more complicated than that, but that'll do. So what occurred to me after all of this is that it really matters, or what we're asking when we ask about, did COVID affect people's social worlds, is really, does it matter which of these things you do in person? Because what COVID did is it presented us with a natural experiment where you really were supposed to shut down almost all the in-person contact with other people unless you lived with them. Certainly that's what it was like in the US. Did everybody follow the rules? No. So does it matter if the social's in person? And the answer is yes. When the COVID pandemic started, it was March 2020, NSHAP was about to go into the field with the 4th round of data collection. 2 hours in the home for 4,500 people. It's a 1-year-long, huge and hugely expensive effort. Well, it became clear to us we weren't going to be able to do that.
Didn't you compensate the interviewers?
The interviewers?
Interviewees.
Yes, we did. We gave them a $100 thank you. And this is just a little survey craft. As we got to the end, as you get to the end of the field period, the people who haven't done it yet are the people who are pretty crabby. And I was a young person in charge of this at the time, and I said, you know, we just got to pay them more. I mean, we have to let them know that their time is valuable to us. So we started experiments where we gave them more money, and we gave them more money, and it worked amazingly. But here's what happened, especially in the next wave. When in the second wave, we were interviewing the people, but we also added their spouses. If the spouse said yes right away and we paid her $100, and then a month later, we're paying her husband $400. We had to go back and make it equal. But the other thing is that survey researchers have found is that if you get somebody to do it by paying them more money, they don't ask for more money the next time. This is pretty widely found in other studies too. So mostly people enjoy this when they get started. Because we ask you about your friends, we ask you about your kids, we ask you about how sick you are, we ask about doctors. You know, it's stuff that especially older people like to talk to this lady, nice lady with wonderful social skills about. So yeah, they should pay us, right? The COVID sub-study, NIH, and I think this was very smart, offered to all of their ongoing studies the opportunity to compete for money for a COVID-specific study. We applied and were awarded money to not go to anybody in person, but to do everything we could remotely. This was a little bit of a scary time because we'd been doing it all in person, and it's different. So we had to retool a lot of stuff. And then we went to everybody we'd spoken to the last time. So 44 4,477 people. And we sent them a letter asking them to go to the web and fill out about a half-an-hour questionnaire. It turned out that a lot of our phone numbers weren't working, and a lot of people didn't respond to mail. There was a lot of disruption in many things. So we then pushed people to the phone. We do it over the phone or paper and pencil. And we got about 56%. I couldn't remember and I forgot to look it up. But in the mid-50s of the people we'd interviewed the last time. Which we've been getting, of the people we interviewed the last time when we go back to them in person, 80%. So this was a big drop. But this is the first time we did anything on the web. It works beautifully for the people who are willing to do it. They do it right away. The questions, none of them are trick. They're all things you can do on the web, and we get the data immediately. So that was wonderful. But we got complete information from 2,554 people. Okay, what we mostly did was we asked them about their experiences during COVID. That was the whole point. So we took the questions we'd asked before and asked what they did during COVID, with a focus on the social and a focus on their health. So we asked about social contact during COVID. And this time we did, I think, what all of us should have been doing already. We separated, and I'll show you, in-person contact from the other kinds, like video, phone calls, mail. So we asked about how much they were seeing friends and family who didn't live with them in person. And then we asked them how much that had changed during the pandemic. Was it a lot more that they were seeing people in, a little more, about the same, a little bit less, or a lot less? So we have both. And then, we did this sometimes in the stuff I'm going to show you and not others, we could look back to what they said for some of these things in 2015.
Are you concerned at all about them not telling the truth because they're worried about having not gone according to the rules?
Well, first of all, some of these people had been interviewed 3 times already. It was on the web. We give them a complete confidentiality promise. They told us about their HIV status. They told us about their sexual practices. They told us about how much money they made. Did they see their kids? It's always an issue, but my guess is it's less an issue than in most of the stuff we ask them. Okay, we ask about mental health during COVID. Then I'll show you that because I'm going to show you some analyses of this. We ask about how they were doing now, and we ask about how that had changed. And the two of these together it's like binocular vision. You know, if you're seeing out of one eye, you don't get any depth perception. You only get depth perception when you look at it from 2 slightly different angles. And I think that this kind of insight is really facilitated by this binocular vision. And then we ask about health behaviors, and changes in health behaviors. And I'm going to talk about all of those. Okay, so this is the question we asked. Since the start of the pandemic, during a typical week, how often have you had in-person visits with family not living with you? And you can see the categories. Daily, a few times a week, about once a week, less than once a week, or never. And we coded less than once a week, or never as rarely. And then the same question was asked about friends. So how often, okay, this is how often did you see and how do you see in a typical week. And then compared to before the start of the pandemic, how has this changed? Now, we asked these same questions about video calls separately, friends and family separately, social media, phone calls, and Letters? No. Following Claude's advice, we wouldn't have asked letters. And if they said less often, a little less often, or less often, they decreased their in-person contact during COVID. And that's what we want to know, because that's the COVID effect. You were supposed to see your grandchildren. How many of you had a Seder? I mean, people in my community had a Seder where their kids are all around them and they didn't see their kids. They never saw their kids. Their kids did not come for a Seder. It's not the same.
Some were COVID positive? Or?
Nobody COVID positive.
No, here they were excluded?
Oh, no, they weren't excluded, no. We asked them if they'd ever been tested positive for COVID. And we actually, in initial part, we gave them antibody tests. I got an antibody test as a pretest. I didn't have any. It was a big disappointment. Compared to the pandemic, so these are the measures I'm going to use. How much contact did you have in person with family and friends living outside the household, and how much did that change? So then what I want to see is how did that affect mental health, emotional well-being? So we looked at happiness. If you were to consider your life in general these days, how happy or unhappy would you say you are? Unhappy, blah, blah. And this one we used as linear. We didn't dichotomize it. Depression, felt depression is one question. How often during the past month have you felt depressed? And loneliness. The loneliness is an item we developed from a much larger scale that we've used extensively. So it's very nicely behaved and it ranges. So we use the whole range. Questions on this? Okay. This is the responses we got to the in-person social contact question. So I have a little pointer if I can figure out. This side? There? Okay, so this is people who say that they decreased in-person contact with family, 38%. Decreased, they have less now than before COVID. They see their family outside the household and their friends outside the household less in person, less now than they did before COVID. So it's about 40%. And these are people who now don't have much contact with their family or friends. Some of them obviously didn't before. So the question is it not seeing people much, or is it a decrease? And does either of them matter? So I'm sorry I didn't put the citation on here. This was published in the Journal of the American Geriatric Society about a month ago. I'm sorry the colors are not coming out quite as strongly as I'd like, but this is decreased in-person family contact. These are unstandardized coefficients. So the only two that are statistically significant are decreased in-person family contact and decreased in-person friend contact. Happiness. So if you said you're seeing your family, if you said you're seeing your friends less than you used to, then you are at increased risk of being less happy than you were. Then you can see that increased phone contact, nada, nisht. Increased messaging, nah. Those text messages, increased video, nothing. They do not reduce the negative effect of less in-person contact. You cannot, we found, on average, substitute video calls for in-person contact and maintain your level of happiness. This is really clear. to increase friend contact, exact same thing. Everybody else didn't see a significant change. People who saw their friends less were less happy. That's a little, I mean, statistically, that's not quite the right way to say it, but it gets the message across. Okay, depression. More depression, more likely to be depressed, more likely to be depressed, nothing else. And it doesn't reduce the effect. People who saw their friends, family less were more likely to become depressed. And here's loneliness. Lots lonelier. Now, this is the only place, family and friends had the coefficients about the same size, but look, the friend contact, decreased friend contact, really, really increases, almost double the size, yeah. So not seeing your friends less is both of them increase the risk you're lonely or the level of your loneliness, but friends especially. But for all of these, increased other kinds of contact don't help. They don't make things worse. They don't make things better. So, okay. So just really quickly, seeing family in person, I spent a little time making this slide, so I'm going to show it to you. Reduced happiness, increased depression, increased risk of loneliness. Seeing friends less often, sorry for the color palette, reduced risk of being happy, increased risk of depression, and increased risk of loneliness. Such a consistent story for both kinds of social contact. And, you know, that's not so standard in our work. Okay, so mental health, the social isolation from COVID reduced on average mental health for people who, you know, actually followed the rules. So what else could COVID have done? Well, one of the other things we ask about was health behaviors. I just found this in the New York Times. Excessive drinking rose during the pandemic. Here are the ways to cut back. Many Americans increased their alcohol intake during the pandemic, with women and parents of young children disproportionately affected. So let's look at drinking. So what we decided to do was look at health behaviors. And what we have in the COVID study and in NSHAP is alcohol consumption, physical activity, exercise, smoking, and quality of sleep. So we looked at all of those, and we looked at both, and this is where I love this part of the design. We looked at both what they say they were doing now, and we coded that. I can tell you, hang on, nope. We coded each of these health behaviors as risky or not. The National Institute for Alcoholism and Alcohol Abuse says 7 drinks a week for women, 14 drinks a week for men, no more than 3 or 4 on a day, and we coded that separately by gender, how much they said they drank and whether it was risky. We looked at physical activity, and people who said they didn't do anything more than once a month were low. People who smoked were doing something risky, and people who said that their sleep was often or usually restless were coded as having poor sleep. Okay, this is the part of it I wanted to show you because I think this is so incredible. This is low physical activity, what they say they're doing now. This is for people who rarely see family, and these are odds ratios. So if this is called box and whisker plots. So if the whiskers go over the line at 0, it is not statistically significant. So we also, we put up the little stars too. So people who rarely see friends, family who rarely see friends, nothing. They don't have lower physical activity, and this is important. This is the objective measure, what they say they do. This is how they say it changed. If they say they're getting less exercise now than they were before the pandemic, then they're here. So you can see that nothing matters of these: decreased family, decreased friend, rarely see family, nothing. But for reduced physical activity, they perceived that they're getting less exercise now than they were before. You can see that decreased family contact and decreased friend contact increase the risks that they said that they have reduced their amount of physical activity. So what you can see here is it's not how often they see family and friends, it's whether they reduced it, like we saw with the mental health, and it's not low levels objectively, it's that they think that their health habits have gotten worse on this dimension, which is also pretty amazing. We see exactly, who picked these colors? They show up on my screen better. What you can see here, heavy drinking, I think this one's actually sort of interesting. Nope, it's not. This one, look at how huge that is, but it's still not significant. The only ones that are significant are perceived increased drinking and perceived decreased social contact. Nothing else matters. How much you see family and friends doesn't matter for drinking or increased drinking. And here it is for smoking. And what we see, and this is the only exception, people who rarely see family increase their smoking. Maybe the people came to see you couldn't stand all the smoke. Now that they're not around, you can just smoke as much as you want. And it's only decreased family contact. No, I'm sorry. That's the only thing that, it's a little hard to see the stars. It's only not seeing, now remember, only 200 people in the study smoked, and they're the only ones we can look at here, so it's not a big thing. And it rarely see family sort of fits the pattern. Okay, and this is feeling rested, and here we're back to what we were before, but here it's only decreased friend contact that's significant. This shows the same pattern, but it doesn't quite reach significance. So feeling like you see family and friends less often makes you feel like you're not sleeping as well. So what's really powerful here is that it's the change. It's what COVID did to you, not maybe you're always a poor sleeper. And it's your perception that your health habits have gotten worse. We can talk about, well, no, I guess we're going to do it now. I made this slide. People felt like their health habits got worse, even though we don't see this objectively. So why could that be? Well, first of all, the objective measures how much do you don't really take into account how important it is. So you see your grandchildren not at all. Is that okay, you didn't see them so much anyway, or was that really a problem for you? Were you an exercise fanatic or somebody who it was very important to and now you had to cut back, so it's really, made your life worse? I was certainly in that category. My pool closed. I was miserable. And we don't take that into account in these. And it also doesn't take into account, maybe if you had that one more drink a week, you feel terrible about it. So it feels like, even though objectively it's a small change, it was an important part of your self-image. We don't know. But the results are screamingly clear on both of these outcomes. I'm going to tell you about one other set of analyses. These are not as far along. These were part of the dissertation of a graduate student who promised me we'd get it done as soon as she graduated, and then she took a job consulting with McKinsey, and hasn't lifted up her head again. So I'll have to find another way to get these done. One of the things we asked also was, because of the pandemic, have you delayed any needed medical, dental, or vision care? So I'm just going to show you some preliminary results, but they're sort of interesting. These colors, I even bolded all of these. So this is the share of people who said they delayed needed medical care. There's 32%. Needed dental care, 40%. Needed vision care, 25%. I wondered about the dental care because I had to cancel a dental appointment and then they could never reschedule me. And when I got back in, I complained to my hygienist, and she said, we had 4 hygienists, 2 of them quit. They didn't want it to breathe in anybody's mouth. They didn't want anybody breathing on them. So the provision, the supply of dental care went way down.
When was this done?
This was the COVID study was done between October 2020 and the end of January 2021. So it was the first year. Yeah. So about a year ago. And things could have changed. So I'm just going to show you what we're finding. And as I said, we're still working on this. We asked people how concerned about the pandemic we were. If they were highly concerned about the pandemic, and on average people were, they were more likely to delay medical care. If they said they needed emotional support from outside the household because of the pandemic, they were more likely to delay needed medical care. If they needed help with daily tasks from outside the household, ditto. If they wanted to see friends more than they in person, more than they were more likely to delay. If they felt anxious, if they felt isolated, and if they were financially worse off because of COVID, they were more likely to delay needed medical care. We still have to nail this down, but we've been nailing for a while, and so I feel at least okay about telling you this much of it. So what I take away from this is that there's pretty clear evidence that declines in in-person social contact led to declines in emotional well-being. That declines in in-person social contact led to at least the perception that one's health behaviors had gotten worse, and that declines, and that not having the social context you needed increased the risk that people reported having delayed medical care. So what do we take away from this? I was thinking this, when I'm a social scientist, I think the social stuff's really important. And when we started closing schools, locking people down, I kept saying to my husband, who's a physician, maybe we should give some weight to people's emotional health and their social relationships, and maybe the Borsiks really should be having a Seder with their grandchildren. Maybe it's worth the risk. And he would say, but a life lost. And I think that's what we did mostly. We said, oh, not the guidelines, not what people did. And we didn't give any weight to the real costs of these social and educational and economic choices that we were making. I'm not saying we should have put people at risk. And we didn't know then, especially at the start, a lot of the things that we know now. But now we could design an intervention where people could be masked and distanced, and like we're doing now, and be in the same room with people they love, and do it pretty often, as long as they did those things. So I think policymakers should push to have these social and emotional components of health included along with the disease components of health. And I think as researchers, and I've just come to this realization, and I designed a lot of these questions, and they're from what standard practice. I mean, Claude said that they ask about in person, but in most of the stuff that we've done, we never ask. In our network measure, we just say, how often do you talk to the people? We don't know if it's on the phone or by video or a chat or in person, but it matters a lot. Here, I think this shows us that we have to know who people are seeing in person. I also think that seeing other people, you know, we're an animal that was designed to live in small social groups with a lot of co-living and intimate contact. And when we don't have that, we don't do as well. That is a component of our well-being. So I think that it ought to rise on the priority of the things that we consider when we're thinking about how do we maximize the well-being, avoid disease, but not do a lot of other damage by, not avoid one kind of damage by doing other kind of damage. Thank you. Toda rabah. You gonna take that? There's some. Oh, you need that. There's. Oh, okay. There's somebody.
That one I'll keep. Thank you.
Let me take all my stuff. And I didn't even need it.
Okay, so Linda, thank you so much. This time I know there's some deja vu because I've been here before, but I'm actually going to open up with a question because I can't resist. Or I can resist. Okay. So when you're talking about human beings designed to be living in social contact, it made me think of these foundational works like Paul Ekman's Facial Codes, and then Randy Collins talk about social about interaction ritual chains. These are the basic idea for some of you who don't have the benefit of being socialized into sociology is that there are rituals which occur on a day-to-day and informal basis when we have social contact, and these when they're not forced rituals, when they're things which emerge organically in a naturalistic way. They are things which are very they promote well-being in all its forms. So, like in that respect, there's certainly a good fit with your findings. But I'm gonna jump off that into a question, which is there's also a foundational finding in sociology amongst other social sciences that there are differences in the intensity of social contact across groups. However you define the boundaries between groups, if it's class or ethnicity or anything else. So my first question to you is a simple practical one, and the rest I'll leave for later. Did you break down any of these findings in your U.S. population by things like educational class or racial ethnic groups?
So on the delayed healthcare paper, one of the things that slowed us down a lot is we started with a vulnerabilities perspective. So we know that in the U.S., COVID took 3.5 years off the life expectancy of the black population. and 2.5 years off the life expectancy of the Hispanic population and 1.2 years off the life expectancy of the white population.
Here
It was
was 3 months.
3 months.
3 months. Israel.
That's it?
It was no, it was 2.5 months. But what we don't know, is what the difference. We don't yet know what the differences are between the Arab and Jewish population, because we do know that the hospitalization rates were much higher in the Arab community. So we're still
Pretty much higher in the Arab.
yeah,
Yeah, like
but not on the scale.
So Israel had very, very low death rates from COVID.
early on, yes.
We'll talk about it in the next.
Yeah, okay. So we looked to see whether, in fact, there were differences in the risk of delaying care. And what we found was there weren't. So we couldn't figure that out. There were no differences. Though blacks were, like 80% of blacks were highly concerned, and 75% of Hispanics were highly concerned, and 70% of whites were highly concerned. Controlling for concern didn't change anything. Blacks may have been concerned. They went to the doctor anyway. So we looked and didn't find on that one. On the other two, we just controlled for. This is the first stage out, and time is of the essence in these things. So we didn't do any more than that, and it was only in the delayed care.
All right. Okay, we'll open it up to Leora. We haven't heard from you yet. Yes, and then Helen after.
Thanks, Linda. I'm wondering if what these findings can help us, and in general, your study, your study in waves longitudinally, in general, to understand about the ideal or more optimal living structure, let's say, for older individuals. Like, for example, if we take the options of living at home with assistance, living in nursing home, living in an independent living facility or retirement facility. I think a lot about the context and the social opportunities in those different, senses. And I'm wondering if you found something in your research, in this wave or, in other waves, to really be able to help us point to a more optimal environment.
So we don't follow people into assisted living or nursing homes. And we didn't impanel anybody in a nursing home. The challenges of gaining consent, especially if there's a proxy, you have to go through a gatekeeper were just overwhelming. So we decided not to do that. But let me here's a really interesting factoid. We developed a survey measure of a widely used clinical neurological assessment, cognitive assessment. It was the same one Trump took, the Montreal Cognitive Assessment, and we adapted it and we got it for everybody. So we have an excellent cognition measure. In the third wave, the second wave, there were about 800 people of our 3,377 who scored as having mild cognitive impairment, and something over 400 who scored as having early dementia, and they all finished the interview. They gave consent and finished the interview, which is very nice. On the where people live, there are cultural differences. And aging researchers, loneliness researchers refer them as familistic or individualistic. Think the Scandinavian countries versus Italy and Greece. And where people are happiest depends on the culture. So people living alone are likely to be miserable in Italy and happy enough in Sweden. But it's clear that there was just something today.
Everybody's miserable in Sweden, or is it happy?
But they have such great health care. There was just something in JAMA today, this morning, I saw on my, that people with serious chronic conditions who lived alone, were socially isolated, faced a much higher risk of mortality than if they were not isolated, which makes perfect sense. Isolation is a risk factor. Loneliness, we know, is connected to mortality, but that has to be through, well, we don't know exactly why. If you're isolated, there's nobody to notice that you fell. So sorry, I don't think I answered your question, but apologies.
I'm wondering, is this on? Yeah. I'm wondering closer to my mouth. Oh, that's better. I'm wondering that I think that you said that people had put off medical care and things like that, and that, well, they've gone less to the doctor. And I think going to the doctor is often a social contact for a lot of certainly elderly. So I'm just wondering if you've done any sort of a connection there between, well, in Australia, certainly, you can tell where I'm from.
Yeah.
In Australia, most GPs went to telephone medicine, and telephone medicine doesn't give it to you, doesn't give you the contact. I wonder if there's any study done on that, because I think that half the reason people didn't go to the doctor was because they couldn't see them in person, and they, I don't know, you know.
Yeah, they didn't want or couldn't manage the video.
Have you followed that? No.
No, that's a great idea. Well, I'll send you the link to the data.
I love it. Thank you.
No? Yes, sort of that or the person behind. Good, thank you. And I can just see a hand, but hardly a face.
Hi, thank you very much.
It's in exchange for the chocolate tart you gave me at lunch.
Yeah. It was a good suggestion, yeah? What I wanted to say was that if you look at your data, in a way there isn't much new there. The newest thing is a separation between the types of social communication and social contacts, which is great. But what you showed is that the perception is what matters, okay? Now, I really want to congratulate you for that, but you can even make it more strong. You can make it stronger because you've got some gold in your hand. You've got a longitudinal study. What about looking at what they said in the previous? It's the same cohort, right? So
same people.
The same people. So instead, showing that the objective measure of change, does it matter the same as the subjective measure of change?
It doesn't. We did that. No, the objective measure of change really doesn't matter much at all. But it's been 5 years, so that would show you it doesn't show you since the pandemic. But yes, we have done that. We can do it, and it doesn't show much of anything.
So then maybe people would believe that self-rated health is the best predictor of mortality.
And
yes.
It is. It's been shown time and time again.
Yes, we know that.
Well, yeah, well, that wouldn't be news. So I'm going to ask one question, which I was hoping that somebody here would. This is more important. And this is a question which he's not going to ask. Nobody's picked up on the substantive differences between what Claude presented and what Linda presented. I mean, Claude pointed to historical examples in which some of the observations of contemporary people trivial were shown with some time to be, let's say, not so valid, and is then leaning towards, if my understanding is correct, leaning towards saying that we will go back to old patterns just because of the way we always do. There are larger structural forces which push us back. So the question which I want to pose to you, Linda, is if you think COVID is just something one other trivial, historical experience in the big picture, or actually is it going to push us into new forms of something else, like this new consciousness of the importance of in-person social contact? Is that important?
What I was going to say is, I think one could argue that people got used to more time alone, that they'll just feel more comfortable with it. That if you haven't had various kinds of social contact with other people for a couple of years, then you might not want to go back to exactly what was before. You might go back, some people anyway, less.
Mm-hmm. So we'll all become Swedish, basically. This is making us Scandinavian.
I can't imagine that.
The climate will become more Swedish.
Yeah.
Sweden will become more like Thailand.
Yeah. All right. Nadav. Tocha.
Oh, it's over here. Coming over here.
Yeah, and this is the last question.
Thank you for this important lecture. I just want, it's a bit of a common question. Dr. Miri Mizrahi is here with us, and she'll present later. We were together on a committee, and this was exactly what we said all the time, that in the indicators we're not including, these other factors. I'm sitting on the advisory committee. I said it time and time and again, and people were very, there was resistance. We have a dashboard with different indicators. So I wonder if you tried to convince policymakers. And also, I want to say, and I hope that TAO will follow, because we are in kind of dialogue with the University of Washington, with the IHME, to try and do some burden of disease thing.
That'd be great.
And
wow.
To include other factors. So it's more like an offer to continue this kind of venture.
It's a great idea.
Because I think that you're absolutely right, that you're not taking into consideration so many aspects. This is true for COVID and non-COVID. And in the discussion about, and I finish, in the discussion about, these two great keynote that in some way presented maybe two different polls, I'm kind of in between, and I think this global, local, hybrid, we will not return to the same place, but we be in another place, not the current one.
That's a great point. And just to say one thing, there has been some movement, in the national accounts to add happiness, to add life satisfaction as worth as much as money, or at least another thing to consider. And loneliness would be a great candidate, because now the UK has a minister of loneliness. And we've shown that it's as important for mortality as smoking. So, if you could get a social indicator into the burden of disease, it is. I mean, and of course, mental health, which is a huge burden. That'd be such a step in the right direction, many steps in the right direction.
Linda, thank you so much.
אני אומרת שמדינת ישראל קיבלה כהחלטת ממשלה את אימוץ מפת המדדים להזדקנות מיטבית, ויש שם ציר אחד של באמת בריאות והתנהגות בריאות,
הציר הנוסף של חוסן כלכלי, והציר המרכזי של משרד הרווחה עם ג'וינט אשל עובד על הציר הזה, זה באמת משמעות והפחתת בדידות. אז אני חושבת שזה הכל מתחבר לכל מה שנאמר היום, ותודה רבה.
Magniv, do you want me to translate? Yeah. Okay. If I remember everything, so the Ministry of Welfare here is working on three axes to include measures of, like, amongst other things, loneliness and mental health and physical health. So,
And what?
And social resilience.
She said welfare.
Welfare. Okay. פשוט, אני לא רשמת את הכל, אז לא נזכרתי, אבל תודה רבה. So thank you again, Linda, very much, and thank you all.